Welcome, everyone. We're going to get started here in a minute or two. Give everyone a chance to get settled and join us. Alma, did you want to kick it off? Were you going to make some comments first, and then I'll get started? Then I'll get right into it. Logistics, or
sure, sounds good.
yeah,
I think people are still trickling in. Let's just
oh yeah, let's wait. Let's wait a minute or two.
Yeah, absolutely.
Thanks for joining us, everyone. We're going to get started in about a minute. So.
Welcome, everyone. We are going to start. It's about 1:30, 1:31. Welcome again. My name is Elma Johnson. I am the program coordinator at the Public Health Center of Excellence on Dementia Caregiving. And on behalf of our team, of our center, I would like to welcome you to our first event, this webinar today, From Data to Action, using the BRFSS to advance the public health agenda of dementia caregiving. We are thrilled to see such a strong attendance and with larger representation from public health agencies from all across the country, and have a great lineup of speakers. We hope that you're going to find today's event useful and helpful to your work in your states. This webinar wouldn't have been possible without collaboration with the Alzheimer's Association in New Jersey, the North Dakota Department of Public Health, and the SCP firm. Before we begin, I would like to just ground us in this moment to acknowledge that the University of Minnesota in the Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. Welcome to our speakers. First, we will be hearing from Phil Echvarria, who is the Director of Government Affairs of the Alzheimer's Association in New Jersey chapters. He first joined the association to address the growing prevalence of the disease in New Jersey. When the pandemic hit, he quickly turned his attention to the crisis in long-term care, where over 40% of residents are living with Alzheimer's or another form of dementia. Prior to joining the association, Mr. Echvarria served as a Director of External Relations and of Community Relations for CarePoint Health, one of New Jersey's leading healthcare systems. Then we'll hear from Janna, who is the Director of the Division of Health Promotion at the North Dakota Department of Health, which includes the oral health, diabetes prevention and control, hypertension, and cardiovascular disease prevention and control programs. Janna has been a member of the National Association of Chronic Disease Directors since 2012 and is the co-chair of its Cardiovascular Health Network. She provides oversight for all of the programs within the Division of Health Promotion and drives collaboration among all of the chronic disease teams to make a comprehensive and concentrated effort to improve prevention and outcomes of chronic diseases for North Dakotans and nationally. And last but not least, we will hear from John Beilenson, who is the president of SCP, Strategic Communications and Planning, a socially responsible communications and public relations firm in Philadelphia. For more than 30 years, SCP has worked with a wide variety of nonprofits, foundations, and government agencies to help them use communications to create social good. In particular, John and SCP have special expertise working with national and state groups that are preparing our communities for the growing number of older adults in this country. As he likes to say, we're helping people get wiser about older. Before I hand it off to our director, Dr. Gogler, just a reminder that today's event will be recorded, and the recording will be available in a couple of weeks on our website as soon as it goes live. As you hear from the speakers, feel free to drop in your questions in the Q&A feature in the webinar, and we will take them for sure at the end, where we have reserved the time for Q&A. Might be able to also take them throughout the presentation if time allows. So without further ado, Dr. Gogler.
Thank you so very much, Elma. Thank you so much to our speakers, to the Centers for Disease Control and Prevention for supporting all of this wonderful work. And thank you to you, the attendees. We are so thrilled that you're joining us here today. As Elma had mentioned, this is our first official, primarily sponsored Public Health Center of Excellence on Dementia Caregiving event. And what I wanted to do is just give a brief overview of our center, how we're really here to help you. And when I say you, I mean public health entities of all kinds, tribal, local, state organizations who are in this public health space, to help elevate the issue of dementia caregiving as an issue of public health import, to help better serve families, friends, and other unpaid individuals who are providing care to people living with dementia in our communities. And again, to be a resource to all of you. And so again, we're just thrilled to have you join us here today. You know, our goals really are threefold. We hope as a center to help you in your work improve access to evidence-based programs and best practices where appropriate. We're very interested in facilitating connections and collaborations, acting as a convener of sorts amongst public health agencies, the Aging Service Network, other key stakeholders to, again, ensure that we can best support caregivers of people living with dementia. And then finally, we also are available to provide technical assistance to you when it comes to identifying key resources, information, perhaps even evidence-based strategies that then can be potentially implemented on a public health scale. You know, we have a very robust network of organizations that are part of our center. We include, I believe at last count, roughly 17 national organizations that all have a robust representation and involvement in our center. And because of that, we have a real richness of expertise that, again, is designed to help you and support your efforts at the state level, local level, again, as it relates to dementia caregiving. Next slide, please. So quickly, the BRFSS for short, caregiver module. Many of you probably are very familiar with the BRFSS. Others may not be. This is the caregiving module in particular, which is a module or component of the larger BRFSS tool, is optional. Along with the cognitive decline module, it includes 9 questions. It's administered intermittently. Depending on your state. And what it does is it identifies the relationship to the care recipient and also collects a number of other key information in a very brief, concise fashion related to caregiving. And what we wanted to do today is, as you'll see shortly, or at least at the end of the presentation, there already are a number of wonderful resources that provide great overview of BRFSS. And we will point you to those as part of this presentation. But the reason why we wanted to kick off our formal events and engagement with this particular topic was we have heard from multiple states and others of some of the really exciting things they've done after the caregiving data has been collected in particular. And when I say exciting things, I mean taking the data and actually influencing policy, influencing programmatic innovation. And we thought this was a timely module in that there already, again, exist wonderful overviews of what BRFSS is, what data is included, infographics that can be generated from the data. But what we wanted to show you today were some case examples of how this can be used for action, and specifically how it can help you achieve some key goals in your states or communities to, again, advance this issue of dementia care as a public health issue of importance. And here are some state examples for you. You can see, I'll just pick a few of these here. Louisiana, they developed training for supervisors at their health department to support employees who are caregivers, again, based on data collected from the BRFSS caregiving module. Kansas educated state legislators about Alzheimer's and caregiving issues, utilizing data collected from the BRFSS caregiving module. And there are likely many other states that we're not capturing here. And two that we were fortunate enough to engage with and who are willing to present here today are New Jersey and North Dakota. And so I believe the next slide, we are going to be turning it to Philip in New Jersey. He's going to tell us more about the BRFSS's impact in New Jersey, and specifically the caregiving data and how it's influenced policy change in New Jersey. Phil, please.
Thank you, Joe. Did I come on camera? It's hard to see.
Yes,
Okay,
you're on, Phil. You look good.
Thank you. And Joe, what a wonderful overview of highlighting what BRFSS can do in each state. And I appreciate that brief introduction. My name is Phil Echvarria, and I'm the Director of Government Affairs for the Alzheimer's Association, Greater New Jersey and Delaware Valley chapters. It truly is an honor to be joining you all today to discuss a topic that has steered policy changes in New Jersey surrounding Alzheimer's. As someone who was a caregiver to a family member with Alzheimer's, this issue is near and dear to my heart. And I truly believe when you pull together a room full of individuals like yourselves, it can be the first step into big policy changes. And while the road is long, it all starts somewhere. And having the tools and data like BRFSS help us to understand the direction that we need to go and to help those in need more effectively. Next slide. Oh, you're already there. No, sorry. Back to the introduction. Thank you. But just a brief introduction of the Alzheimer's Association and the role we play in our communities. Our association is the third largest funder of Alzheimer's research worldwide, behind China and the US. The Alzheimer's Association strives to live in a world without Alzheimer's and other dementias. We are working to achieve this through a multi-pronged approach by funding research, supporting our communities with educational programs, and effectuating the policy landscape to ensure that the system works for all. But like many organizations, information is critical for us to know where we need to deploy our resources. It helps us to understand the needs of our community and what policies we need to pursue. Next slide, please. This is just a quick snapshot to help paint the picture of Alzheimer's and caregiving in New Jersey. Currently, there are 190,000 individuals living with Alzheimer's in the state, and that number is expected to grow by 10% by 2025 to 210,000 people. The number of Alzheimer's caregivers is 347,000 individuals, nearly double the amount of people diagnosed with Alzheimer's. And as the baby boom generation continues to age into retirement, we will see an increase in Alzheimer's and in caregivers. Now, the next two data points always stand out when I meet with legislators. Caregiving continues to be a situation where many do it, little attention is drawn to it, and it impacts every facet of a person's life. Here in New Jersey, it is estimated that 658 million hours of care annually are provided by caregivers, which can equate to $12 billion in unpaid care. That is massive. And this has the potential to have a negative domino effect. If caregivers cannot work due to the demand of caregiving, the state can lose tax revenue. Lower tax revenue can impact the services that caregivers rely on, which can cause even more financial burden to the individual, especially if they're paying for private services. Which is why progressive policies are critical to ensure that we are protecting our most vulnerable. And these policies need to be supported by clear and trusted data. Now, New Jersey didn't always look at Alzheimer's and caregiver information with this much detail. In fact, the BRFSS caregiver module cracked that conversation open back in 2017, and it came into play right on the heels of a legislative report. Next slide, please. Flashback to 2016, New Jersey began to look into the impacts of Alzheimer's and other dementias. They looked into the impact it has on the individual, on the caregiver, and on social services. And this was done because the legislature saw the growing impact of Alzheimer's and the impact it can have on New Jersey without intervention. So they passed legislation that would require the creation of an Alzheimer's state plan. The state plan addressed several topic areas, but most notably, it focused on increasing awareness, expanding support services for unpaid caregivers, promote more comprehensive infrastructure surrounding the disease, and public safety and legal support for families. This was a big step for our state. We set out to identify the problem, we brought together the experts to analyze it, and we created a roadmap to address it. Many states have similar plans, and I'll take 2 seconds to say this. These state plans are incredibly helpful and should be updated every few years to ensure that they are addressing current and relevant issues. In New Jersey, we continue to address each topic area. However, expanding support for unpaid caregivers became a rally point, not only for us, but many others who found themselves in a caregiving role. Next slide, please. Caregiving needs vary from illness to illness and from individual to individual. Data like this helps us to understand the demand of caregiving. In this case, we can see the help needed for daily activities is substantially higher in some areas for individuals living with Alzheimer's. This information is robust. However, as we all know, policy needs can vary from state to state, county to county, and even town to town. Next slide, please. It's cut off at the top a little bit, but I think we can understand the slide in its own. Again, pulling some national data, we can see the impact of caregiving on employment status. This information shows the demands of caregiving impact every facet of life. Work performance can suffer, which can add to the stress that caregiving can have. Data such as this is tremendously helpful to demonstrate a need for robust policies to help every state address this problem. And this information can have a big impact to sway federal policymakers to work towards fixing an issue that is similar throughout the country. Now, the Alzheimer's Association has been consistently successful in influencing federal policymakers to notice, address, and work towards creating policies to help over 6 million individuals living with Alzheimer's. And while this type of information is incredibly helpful, without fail, state policymakers will always ask me this: where is New Jersey's data? So ensuring that we have state-specific information that we can analyze and relate to our own issues is critical, which brings me to the reason why we're all here. Next slide. BRFSS data allows us to collect that unique and critical information that helps our state connect the anecdotal stories they hear to the analytical information they need for decision making. The BRFSS data is robust, which allows advocacy groups like the Alzheimer's Association to further understand the needs of their constituents. In this case, the needs of our caregivers. The fact sheet to the left was created by the New Jersey Department of Health to outline New Jersey's caregivers' needs. To the right, the same data, but interpreted specifically for Alzheimer's caregivers. While the differences may be minimal, it's this data sheet that helps us lobby for progressive policy changes to address the needs of caregivers, especially those caring for an individual living with Alzheimer's. So now we have this information that empirically outlines the stories that we've been telling our policymakers for years. Now what? I often see in the policymaking process, the death of good policy tends to come from one idea trying to tackle a mountain of an issue. Therefore, advocating for one policy to address this massive issue might be too challenging to overcome. So tackling the problem piece by piece can help bring awareness of the issue, achieve more positive outcomes, and allow for adaptation should concerns arise. In this instance, several advocacy groups, including us, expressed the importance of understanding the needs of caregivers in New Jersey in order to address this issue. With a unified voice, legislation was drafted to create a governor-appointed task force to look more deeply into the needs of caregivers throughout the state. This is a big win, and we have the data that we need to back this information. Next slide, please. The Caregiver Task Force legislation was an opportunity to unite advocacy groups from across the state to address a common issue our organizations faced. And while we applauded such needed legislation, the next phase of influencing policymakers began. The task force consisted of 11 committee members, of which 7 were community advocacy groups. New Jersey, like all states, houses many advocacy groups whose mission is to help their state residents have access to critical services. However, with the Caregiver Task Force having a limited number of seats, ensuring that our association was represented would be the next step of this process. I mean, there's really no big plot twist in this story. We used BRFSS data to help demonstrate why the Alzheimer's Association should be on the task force. Specifically, the BRFSS Caregiver module helped us reveal why our association would be a valued asset to the task force. Being able to take information that's endorsed by the CDC, administered by our Department of Health, and authorized by our state not only creates validity for the information, but adds weight to the details it presents. So we took that information and we shared it with legislative sponsors with a simple message. Hundreds of thousands of individuals are impacted by their caregiving role, and the BRFSS data shows that Alzheimer's caregiving ranked high for the need of support. Jump forward, we were successful in being named in the legislation for the Caregiver Task Force. And the task force began their work in the fall of 2020 despite a pandemic, and have been active in hearing testimony from caregivers, administered a statewide survey, and will be providing a list of recommendations to the legislature to enact this fall. This allowed us to lay the foundation for future policy changes. As I mentioned before, a good policy can sometimes die if the problem it tries to solve is too big. But this allowed us to take incremental steps and continue to raise other policy concerns. Next slide, please. We were able to use this momentum to push for more progressive legislative policies. Being able to raise concerns around caregiving allowed us to elevate our voice and bring attention to other aspects surrounding Alzheimer's. We were successful in introducing legislation that would create an Alzheimer's public awareness campaign with additional focus on educating those professionals who work with this population. This included first responders, social workers, and financial planners. Raising awareness would be our next step in helping to end Alzheimer's. Next, we worked with key legislative partners to provide input for an Alzheimer's and Dementia Long-Term Planning Commission. Proactive planning will allow us to address the growing problem that ensures families and individuals have access to resources they need to age in New Jersey. These two legislative priorities will help us continue to change the policy landscape to further help the 190,000 New Jerseyans living with disease and be proactive in combating the growing incidence of Alzheimer's. And while I'll talk about how this kind of data can help in the lobbying process until I'm blue in the face, breakfast information helped us add community engagement efforts. Our state and local agencies do an incredible job to serve their constituents. However, groups like the Alzheimer's Association can help bridge that gap between community needs and community resources. While we welcome legislation that would create a statewide public awareness campaign, there is still so much that we can do at a community level to help raise awareness. That's exactly what we did. Working with Rutgers University's Aging Brain Health Alliance, along with several other local religious, healthcare, and state entities, we were able to hold a community event focused on educating men on brain health. Statistically, men go years without a visit to their primary care physician, which can lead to negative health outcomes. So starting a grassroots efforts to raise awareness about healthy brain habits allowed us to work directly within our communities. The program was focused on around an antique car show, which helped draw in the crowd. And we were fortunate to have local food establishments donate food for the event. The day gave us an opportunity not only to help educate attendees about brain health, but foster a community network of state, local, and health advocacy groups, all there with one common purpose, to help the constituents of our state. Next slide. So what's next for us? I mean, fingers crossed, the passage of our two legislative priorities would be a huge win for us in laying the foundation that we need to make New Jersey a more dementia-friendly place to live. But also, like every state, the pandemic has shined a light on a number of healthcare issues. It will be a long time until we're able to understand the full breadth of the situation. But as we continue to draft policies, having adequate data points is key. Having more information on the pandemic's impact on caregivers and cognitive decline due to social isolation will help us plan out our engagement with policymakers. More specifically, in New Jersey, we will continue to use the momentum that we're having from the Caregiver Task Force to push more progressive policies, and we'll use the data to determine what the need is. See, the beauty of breakfast is it creates a baseline every time it's administered. We're able to see where the changes are, where the pain points are occurring, and where we need to adapt. However, the caregiver module isn't always on the forefront of our breakfast coordinator's mind, so it's up to advocacy groups like ourselves to advocate for its inclusion. And for those on the call who work on administering breakfast, I urge you to continue to include the caregiver module. It helps advocacy groups aid their constituents and guide policymakers to new issues they need to address. The use of breakfast helped demonstrate the need for policy changes and helped us take a deeper dive into helping the caregivers in New Jersey. And I have no doubt that the data can help paint a similar picture in every state. All it takes is a starting point. Next slide, please. I just want to take this opportunity to thank you again for having me and to tell you that I appreciate all the work you do. The past year has drastically changed the way many of us operate, but I'm hopeful that through this disruption, we can take the new practices that we have learned to better serve all of our constituents and stakeholders. Thank you, and I'll turn it over to Joe if there's any questions.
Great, Phil. That was wonderful. What a powerful demonstration of exactly what we're trying to achieve here today. I think many of us are trying to achieve. So thank you, Phil. Again, attendees, if you have questions, additional questions, please feel free to use the Q&A tab at the bottom center of your screen to pose them of Phil or anybody else. We do have a question for you here, Phil. And Can you give an example on how you used or presented data to policy and decision makers to create a sense of urgency to take action? What type of data has been the most helpful or effective with legislators? If you could share, that would be great.
Yeah, I mean, that is a great question. Caregiving is one of those things that is far too common and so many people do it. And what I think is interesting is many don't classify it as caregiving. They don't talk about it, or they don't see that there's any other option. In my experience, when talking with legislators, they too see the issue hit very close to home. The demographic of those who are caregivers is not equal. Caregivers impact women more than men. It tends to happen in the height of people's careers, and nearly 2/3 of those providing care of those with Alzheimer's, that care goes on for more than 2 years. Without proper support, caregiving will impact New Jersey's workforces from ages 45 to 65. More specifically, it will have a higher impact on the employment of women from the ages 45 to 65. So in my conversation with legislators, I try to explain that without proper financial and program support, caregiving will continue to have a higher impact on women in the workforce. Unpaid caregiving still costs a lot. It directly impacts your potential workforce, which then impacts state dollars. I mean, if you really want to create urgency, show a policymaker that state revenue might be impacted, and you'll have their attention every time.
Thank you, Phil. That's great. Really appreciate it. All right, what a great way to kick off our session here today. We are now going to turn to North Dakota. We have Janna Pastie with us from the North Dakota Department of Health. Really thrilled to have you here, Janna. She's going to talk about North Dakota chronic disease and BRFSS data-driven programming. I'll turn it to you, Janna. Janna, thank you.
Hi, and thank you so much. I'm really excited to share how North Dakota has used the subjective cognitive decline and caregiver modules to enhance our other chronic disease programs. When these modules were first presented to the BRFSS committee in North Dakota several years ago now, we didn't have any additional funding with our BRFSS program to support either module. But I had actually recently been put in charge of helping to improve care coordination and resources for families of cancer patients and survivors. So knowing the types of questions that were in the core and then the questions that were going to be included in the caregiver module, I knew that I could leverage my funding to fund that module and to be able to gain a better understanding about the number of caregivers we have in our state, the types of conditions that those family members were having to deal with, their own health and ability to care for others, and areas, specific geographic locations in the state where they might be living, so that we could target our resources and programs. So I actually helped fund the very first module in North Dakota using the Comprehensive Cancer Control Programs grant as part of our data collection. Next slide. Thank you. So we had to make the case for the data use in North Dakota. Of course, when you're using federal funds, you have to be able to justify that the use is appropriate. And so the caregiver module actually includes the questions about other potential conditions a person has, and cancer was one of them, as well as diabetes, which is a program I'm in charge of now. So our data that we use from the BRFSS Alzheimer's related modules has been able to be cross-responded with other chronic disease, mental health, and access to healthcare questions that are part of the survey every year. And we use that to identify priority populations routinely, especially for chronic disease programming, and the strategies that we are able to implement addressing those particular chronic diseases in those populations. And this has allowed us to gain an even better understanding of delivery models and the potential additional healthcare needs that those individuals would have. Some of those interesting data that we've been able to see as a result of doing that caregiver module a few years ago is that, as you can see here, individuals with Alzheimer's and individuals that are providing care for people actually experience obesity in our state almost 10% higher rate than the general North Dakota public. And that is the kind of data, that's the kind of cross-referenced information that we are able to use as a state in grant applications that may seem unrelated, but allows us to develop a priority population that isn't routinely looked at with our chronic disease funding. So in particular, what we do with this information for our nutrition and physical activity and chronic disease grants, especially for diabetes and hypertension, where lifestyle is so influential, is we look at people's responses to whether or not they are caregivers and what types of conditions their family member or friend is dealing with, and also those with cognitive decline. And we look at the data related to the obesity questions, hypertension, diabetes, and then there's also fruit and vegetable consumptions, amount of activity in a week that they participate in, and then even the frequency in which they attend appointments, which another data appointment that we have seen is that caregivers do not routinely see their own primary care doctors or their own dentists. And I think we can infer that it's likely due to the number of hours that they're providing as caregivers and the number of hours that they are also having to work or take care of themselves or other family members. Next slide. So our data for programming, like I said, we've used other chronic disease grants to be able to fund the modules in our state's BRFSS program. North Dakota does not have any federal funding for Alzheimer's programming. We do have funding for dementia care services in our Department of Human Services. But as we know, that those are much more restricted and based in very prescriptive grant writing. So the data from our modules has been looked at multiple ways for different populations, especially how we could potentially partner with our aging services division better when it comes to chronic disease prevention or management, and then also the individuals around people with chronic disease. We also look at how we can use this for developing programming in our state. And as of right now, we're just in the middle of writing our first plan, but I'll talk about that in a few minutes. So even though we did these modules initially 5 and 4 years ago, we are still not in a situation where we're eligible for the federal Alzheimer's grants, and we are using the BRFSS data to help us create a more comprehensive application for the next notice of funding opportunity. One of the things that we have found most important out of the data, specifically from the individuals that responded to the subjective cognitive decline modules, is taking their responses and comparing it to their physical and mental health questions, as well as their attendance to their preventive health appointments, so that we can identify other common morbidities of these individuals and think through and better provide programming or education for the healthcare providers that would surround them. Specifically, we've used some of this information to help us create education modules related to medication optimization for individuals that have subjective cognitive decline. And it allows us to work more effectively with our specialty care providers, because a lot of times we do not have in North Dakota many specialty care providers evenly distributed throughout the state. And so for central and western North Dakota, individuals may find it difficult to see someone who actually specializes in their condition regularly. And so we are able to better prepare our general practitioners in primary care and even our diabetes or hypertension related specialists in providing care for people with cognitive decline, and the special considerations in their medication and in their care plans related to that. So for North Dakota, we have the CDC hypertension grant, and that is able to be partnered very well as a chronic disease grant with anything that we're looking at for Alzheimer's populations. But there's other grants that have come from the CDC where this type of population would be ideal to be included as a priority, and specifically thinking about the extension of what we call DP 1815, which is the hypertension and diabetes grants. Also the oral health grants, and we have incorporated our long-term care survey data in addition to the subjective cognitive decline data and the availability of services and oral health prevention appointments for individuals who may have cognitive decline, and providers in our state that feel comfortable helping provide those dental care services for those individuals. And so we have looked across all of the grants that we receive as a department and how we can best reach our population that is suffering from cognitive decline to any degree, to implement better care practices across their whole health continuum, not just things that are specific to aging. Next slide, please. So one of the examples that we've come up with really in the past 2 years has been implementing more virtual and asynchronous community-based program delivery options. And as much as I know we want to kind of put 2020 behind us, I think in the public health world, we also have to recognize the opportunities that COVID-19 pandemic response actually gave to chronic disease programs and the world of telehealth delivery and even community-based program delivery. So thinking specifically about some of the changes that we've made in related to the National Diabetes Prevention Program and how it's offered in our state, as well as our Powerful Tools for Caregivers program that was exclusively in person up until last spring, when they started adopting their platform over into a virtual offering so that caregivers could still get those supports and resources they needed at what could be considered an even more critical time in their lives where that support is so essential. What we're looking at for the upcoming strategy integration for our plans and as a State Department of Health is grant applications that are coming through that are related to nutrition, physical activity, injury prevention, diabetes, hypertension, and oral health, all able to use the data that's been collected either between the caregiver module or the subjective cognitive decline module to create populations and to create strategies in those work plans for the next 4 and 5 years that will specifically address the growing population in North Dakota. We do currently have about 14,000 people that are officially diagnosed with Alzheimer's, and we know that that's low because we know from surveys with physicians that they are weary of fully diagnosing a person that way because of what happens in their life once they've received an Alzheimer's diagnosis. But we also know from our BRFSS data that we have over 30,000 people in our state that are providing 40 hours or more a week of caregiving services. This is substantial in a state of our size. And that is just what we know. That is the people that have been reached. So we know that we need to really be thinking through how we deliver programs so that individuals whose time is not necessarily their own are able to participate and manage their own health so that they can be optimal caregivers, but also not find themselves very shortly in need of their own interventions as well. So a small shout out to the positive consequences that came from this pandemic over the last year and the emphasis that it put on technology and the integration of these types of programs to virtual offerings. What we really love through the virtual offerings, especially for the lifestyle management courses that we have as a state, from hypertension, diabetes, and diabetes self-management education, as well as their Powerful Tools programs, is that by making it virtual, we've reduced a lot of barriers to people being able to participate, even beyond having the time. Now we don't have to worry about transportation being a limitation. And what we do know as a state is that nearly 100% of individuals have or have access to a smartphone where they can actually participate in many of these classes from anywhere on their lunch breaks from their jobs, rather than having to take time off from work, or in the evenings when they are, done for their day, just trying to be very responsive to their needs. And so by doing this virtual, we've been able to reduce these barriers for some of the people that probably need these types of programs most. Next slide, please. So program participation. We really look at wanting to be able to create a participation model for individuals that have these types of other life barriers, such as caregivers or even individuals with cognitive decline who may not be able to drive themselves or may not remember, to be present in certain moments, or things that they could be doing to take care of themselves. And so one of the ways that we've tried to increase our reach so that we make sure caregivers are aware of all of the programs that are available to them is by integrating what we call a session zero. And that session zero is the start point for a lot of the different community-based programs we have in our state. And it is basically before the evidence-based part of the classes begin. It's an introduction to those that have signed up to participate in that class. So that, and the example I'll use here is our DPP, because it's where we first started it. Our session zero, the DPP class leaders will introduce and provide resources to the individuals that are hoping to prevent diabetes in their lives, to also be able to benefit from tobacco cessation partnership, caregiver support for the power, if they come to DPP and they identify that they're a caregiver and they're worried that that's going to be one of their barriers to being successful in their DPP program, they're able to be referred directly to individuals that carry out the Powerful Tools for Caregivers programs, whether they're able to participate in the program or just connect with those individuals so they can receive resources one-to-one. We find that it has really benefited the participants in all of our lifestyle modification classes to be able to get kind of cross-referred to the other programs that will help them be the most successful and have the most positive outcomes across the board, not just in maybe what that particular course is meant to address. So really trying to meet their needs when we find these individuals. Next slide, please. So I touched on this part a little bit before about service delivery improvement, especially when we talk about going to virtual options for those classes that we have as a state, and looking at better offering geographically as well by understanding where we have the highest prevalence of caregivers or highest prevalence of individuals with cognitive decline, which we do find obviously our central communities have some of the highest incidence, but we do have some very rural counties that will have a higher than expected rate for individuals in either category as caregivers or as people with cognitive decline. And they may not have in their county direct resources for those courses or for other parts of their healthcare. And we are able to then look at providing a way to deliver those services or healthcare that they need. So ensuring connection is one of our most important things. Connection to transportation services, connection to healthy food. Those are some ways that we're better able to prepare providers of long-term care and individuals with cognitive decline. In addition to those types of social determinant pieces, we have to acknowledge that our pharmacists are able to administer vaccines. In our state, they're able to provide tobacco cessation education and nicotine replacement therapy. They're able to do training for self-monitored blood pressure. And in many pharmacies, they're able to also do medication change needs when people are in between their routine care visits, which for our more rural communities, that is a huge benefit for their pharmacists to be able to provide all of those services. So knowing where we have the highest prevalence and the least amount of specialty or routine care providers, we're able to look at partnerships with those pharmacies to have them practicing at the top of their scope and understanding the kinds of unique needs that some of their patients will have and how they can help them have optimal outcomes. So we also have local public health units in North Dakota. Each of our local public health units operates separate from the Department of Health. So they identify their own needs through community needs assessments every 3 to 5 years, and they develop work plans associated with that. And we do utilize the data from the caregiver module and from the the subjective cognitive decline modules so that they can see the percentage of their population and look at whether or not there's a need for them to increase their capacity for home health services, respite care services, or other types of programming that could be available more locally in their community to provide supports to those individuals. So really trying to make sure that they're at the forefront because they are a really large percentage of our population, given how small our state is. Next slide. And so speaking of community needs assessments, North Dakota, I think it was 3 years ago now, there was the BOLD grant that came out specific for Alzheimer's, and we were not eligible to apply. We did not have a state strategic plan, and therefore we could not apply for the funding. Once we identified that that was why we didn't have any funding in our state, after some conversations with our Department of Human Services, Aging Services Division, we did decide that we were going to move forward and create a strategic plan. So the strategic state plan addressing Alzheimer's and dementia in North Dakota is including sections that are for specific groups to lead. And so far we have categories like legislative response, healthcare response, community needs, local policy, continuing education for medical and healthcare professionals in order to prepare North Dakota for our increasing number of citizens and our expectation of over double the number of individuals with Alzheimer's and likely double or more the number of individuals providing caregiving services within the next 15 years or so. So each group that we've identified that has a stake in the care and quality of life of these individuals will have action steps that they can take from this plan that they can own and implement. And an example that I can use is when it comes to continuing education. We have identified some strategies and activities to implement curriculum change to include in our UND Medical School and our NDSU School of Pharmacy to be able to better educate about community-based programs like the Diabetes Prevention Program, Better Choices for Better Health, Falls Prevention, and Powerful Tools for Caregivers, so that they are more aware when they go out to start practicing healthcare in those communities of the programs that are there to support their patients and how those individuals would benefit from them. So this plan would never have been as robust as it has been, to the point that we've divided it out now into specific stakeholder groups, essentially creating several miniature plans that make up one large comprehensive plan using data that we have gotten from these modules and how we've been able to analyze it with those respondents' other answers to questions within those surveys. Without these modules, we would not know about our pockets of population of caregivers that are in our rural communities that do not have supports. We would not know how truly underdiagnosed Alzheimer's is. And in addition, for the caregiver module, it's not just asking if individuals provide caregiving services for individuals with Alzheimer's, but with other chronic diseases. And across the board, we're able to better provide programming when we understand the types of barriers people are dealing with to successfully manage their own health. So that is all being included in our strategic plan so that we can really put something comprehensive together that gives everybody the tools they need to improve the quality of life of our caregivers and for our people that have identified with cognitive decline. And so that is how North Dakota started using the data and how we are continuing to use the data to this day. We will continue to support these modules moving forward. Honestly, we were very surprised when we got our first round of data, the number of people that responded they were caregivers, and for the types of conditions. Often, if an individual was providing caregiving services for someone with Alzheimer's, that individual patient or family member also had diabetes or hypertension or cancer. And that just really complicates the ability for them to provide care. And it really has been used for us to define the problem related to home health and respite care gaps in our state. And we are looking forward to what that means for policy in our next legislative session and in funding with our health systems to improve reimbursement for those services so that they can be sustainable and so that families can take care of themselves and take care of their family members. And that's it. Next slide.
Great, Janna. This has been wonderful. So we have questions here. So let's get.
Oh gosh. Okay.
Yeah, we have time. So this is great. So Janna, first, how were caregivers defined, formal or informal? How many hours per week? Can you elaborate?
So in the modules, it's pretty informal. The module does come with a very specific script that the survey providers. For us, we use an organization out of Utah, I believe, that they have to follow. And so it is a self-identified caregiver, and they are asked to estimate the number of hours that they spend doing caregiving services for a family member, friend. It is specific, and it does ask in the question that it's not part of your profession, that it is something that you are doing beyond your work. So you as an individual, are you a caregiver for a family member or friend? And then the estimate of the number of hours. And then they do ask the conditions or condition of the individuals they're providing those caregiving services for.
Great, thank you, Janna. And then how frequent are you supporting the caregiver and cognitive decline modules? Every 5 years, every 2 years? Mahalo. So.
Mahalo. I know where you are from. Yay.
Yes.
The modules at this time, I believe we have for every 5 years. Our hope is actually to do it every 2, but our survey is obviously you have a lot of different groups that want to add into those surveys every year, and we do look at how long the survey could potentially get based on expected numbers. Like if we know someone says yes to a question and it's going to open up a module, they could be subject to several modules thereafter. And so we do try to be cognizant about how long the survey is getting and try to make decisions based on that. So right now we're looking at 5 years, and we are hoping to actually go down to just every other alternating them.
Great. And then Janna, another question here. Have you used the data to tell the story at a more local county level? And if so, how?
Yes, I wouldn't say that we've done it in a formal way, but what we have done is when we're looking at, again, I'm just going to use our DPP program as an example because that is in my wheelhouse, in my division. When we look at certain counties, and I'll use our central and western counties as an example, that have higher numbers of people that are either caregivers or identified themselves as having cognitive decline. We also notice or reference that to the number of professional healthcare services available in that county. And a lot of our rural counties do not have something within a 20-mile radius. So they're not routinely seeing their physicians, nor is it feasible for them to be driving to these other central locations. So we have used it to emphasize our support for our local extension agents through our university. Our extension agents are, I believe all of them, at least one in every single county, is trained as a lifestyle coach and is able to then provide that program in person. And now we've adapted it to be also virtual in those counties. And they also are trained and provided the information about the types of patients that we're expecting to see. So they are trained to refer individuals that may show up into their class and during their initial evaluation identify that they're a caregiver and are maybe feel that that could be a barrier to their success. Then that class leader is able to then connect them to the powerful tools folks and other services through our aging programs.
That's great, Janna. And let's conclude with one final question here. What have been your response rates to the BRFSS? And we've had very low uptake of the BRFSS in some populations. What strategies have you used to increase the uptake of the BRFSS in some of the cultural communities in North Dakota?
Absolutely. I don't know if a lot of people know this, but North Dakota did experience an oil boom in the 2010s. And right around that time, when we saw an influx in funding as a state, we did put funding forward, and we continue to, as a state, oversample our American Indian population, knowing that we do have a lower response rate with them. And so we wanted to make sure that we were at least getting a valuable enough sample that we could extrapolate responses. Also, we try to be very cognizant of the zip code that they're responding from, because we have larger tribes, and all 4 of our tribes are very different. They have access to different things. They have different health indicators and different income. And so we do try to be very cognizant about how those samples are being pulled and how we're, more specifically, how we report that data, whether we choose to report it aggregately or if we get permission from the tribes to have certain things separated out so that we can tell a better story for their unique needs. But the oversampling was essential. And of course, it does require, being able to have those survey callers increase the number of calls that they do. We tend to get between, I think, 5,500 and 7,500 responses, which for North Dakota is considered a valid sample as a state. And what we need is really only a few hundred from the American Indian population due to the size that they are in our state, but they are our most disparate. So we do try to get as large of a sample as possible from them.
Thank you so much, Janna. This, again, just wonderful overview and so helpful. We just so appreciate you being here today, and thanks for that excellent presentation. So we're going to turn to our third presenter here, John Beilenson. John is a member of the Bold Public Health Center of Excellence on Dementia Caregiving. He's a member of our executive committee. John, we turn to for expertise in communication, strategic communication, and dissemination. And the reason why we have John here is if you recall, when you registered for this webinar, we asked you to pose several questions that John will actually lend his expertise to answer. So much of this, I think, is based on effective strategic communication, of taking data, influencing decision makers to then lead to change. And again, we're thrilled to have John here with us to share some of his insights and wisdom. Thanks, John.
Thanks, Joe. Again, I'm glad to be here this afternoon with all of you, and very much appreciate the stories that Phil and Janna have told about their work in New Jersey and in North Dakota. As Joe suggests, we're going to pivot here a little bit, and I'm going to make comments less about an individual state's approach to data messaging and dementia caregiving, and make sort of more general comments focused on communications and stronger communications using data to promote the kind of action that we're all hoping for around public health and, of course, dementia caregiving. Next slide, please. So the first thing is, what are we talking about? Well, we are talking about messaging, and as many of you know, a message is a clear, concise statement or set of statements, generally, that describes a position, opinion, or point of view. And so what we are really looking at today is sort of how data fits into the larger effort to message effectively around dementia caregiving, and indeed how data functions most effectively in public health messaging more generally. Next slide. And again, one of the challenges of messaging is that, as we all know, people's attention spans are increasingly short. Even as the webinar sort of rolls on, we are getting emails. There is social media. There is all sorts of things competing for our attention. And in public health and in all actually communications, we are challenged to figure out ways to slip in our messages into places or into the attention packets, if you will, that folks have. And I like this cartoon from the New Yorker. If you were to boil your book down to a few words, what would be its message? And in fact, that's what our challenge is that issues like dementia care and dementia caregiving are complex. They're multifactorial, multifaceted. And at the same time, we are under pressure, if we're trying to be an effective communicator, to boil it down, to distill it in ways that are not only shorter and more concise, but also accurate. That is indeed our challenge. A lot of folks think about this process of messaging as sort of dumbing things down. And in fact, that's not what we're trying to do here, where the challenge is to create language and communications that are broadly accessible, but that in fact communicate the most important parts of the information that we care about and that they need to hear in order to improve their health and well-being. Next slide. So of course, in terms of messages and caregiving messages, data is in fact a key building block of those messages. And as we've heard today, they've been used in a variety of contexts. Data is used from the BRFSS BRFSS, excuse me, modules. We've used that data, and that data has been used in a variety of different ways to promote a number of different aims. And one of the things that I was struck by in all the communications is that, of course, the data doesn't stand on its own, right? It is part of a larger communication, and indeed, the data in and of itself is not sufficient to create something persuasive. You have to do what the folks at the Frameworks Institute call the social math, and to explain to people what these different numbers mean. So, for example, in the caregiving world, we talk about 1 in 6 Americans are caregivers, about 55 million people. And again, that sounds like a lot of people, but what exactly does that mean? Well, that's the same number of all US kids going to elementary, middle, and high school right now. So it is a significant and important population. And again, just as we are concerned about sort of the health and well-being of young people and folks going to school, we are concerned about the health and well-being of caregivers. In the news, as I think all of the folks know, in the last couple of days, the drug and I'm not even sure I can actually say this, aducanumab, was recently approved it was approved yesterday by the FDA, and folks described one of the controversial aspects of it is its price tag, which is $56,000 a year, which again sounds like a lot of money for a drug, although there are other drugs that cost more. But again, today I saw on Twitter folks comparing that annual cost to the annual pay of a full-time home health aide. Okay, so that is again using the data, certainly using a data point like $56,000 a year, but again trying to help people understand what that number means, and to do this what again Frameworks is called the social math. Next slide. The second thing I want to say about data in terms of the messaging is that we oftentimes are overblessed, if you will, by the amount of data that we have, and indeed, as our data gathering and as data gathering in general becomes more efficient and easier, we oftentimes have lots of different kinds of data to choose from and to communicate about. And oftentimes, this is true in the communications field, is certainly in public health, for example, in marketing, where we want to talk about all of our stuff, and we want to make sure that people are impressed by the breadth and the extent of the problem. And indeed, it's really incumbent upon us, as we make sense of all of the BRFSS and other data that is out there, that we find, in fact, the best data possible. And in fact, in terms of strong communications, it is better to find 1 or 2 strong data points around a particular issue that really addresses a particular point or particular concern, than it is to present a whole wealth or raft of information in one place or in a communication. I oftentimes see this in academic presentations, but I also see this in many public health presentations as well, where there is the use of just statistic after statistic to try to create a sense of urgency around the issue. Unfortunately, what we end up with is too much sort of a good theme. I think someone called it infobesity, or data numbing. There are a number of metaphors that people use to describe sort of the effect, the sort of deleterious effect of using too much information in our too much data information, or quantitative data, particularly information in our communications. And as some have noted, oftentimes we may be successful in communicating about the large or broad extent or urgency about a problem, but unfortunately our solutions may not match that broad scope of the problem, and that in turn creates a sense of fatalism, and a sense that in fact whatever, yes, of course we have this huge problem, but just like so many other problems that are out there, there's nothing we can do about it. So again, the judicious use of data, 1 or 2 strong data points per communication versus, again, this whole raft is critical to ensuring that whatever communications you do is most effective. Next slide, please. And then I think the next set of points I'd like to talk about is that indeed strong messages are more than data, and indeed how we use data or how we fit data into those messages is really important. So in our work, we will try to break the or try to ensure that each of the messages that we develop have a strong value or an initial premise that is broadly understood and broadly supported, that then is then sort of followed by or built from an explanation that includes both the problem and its cause, and that ultimately ends with a useful solution. And again, how we choose the value and how we describe the problem and cause so that it fits and rolls naturally towards the solution is part of a successful sort of message making operation. And finding again that single 1 or 2 data points that fit into that argument, into that message is truly critical. And I'll just provide an example here again that I made up for this presentation. We go to the next slide, please. So this is a message that I've thought about, I've framed up, focused on state legislators about this topic of caregiving and Alzheimer's caregiving. So it starts with, again, a call towards a value that all of us, this sort of sense of universalism and inclusion, that all of us in our state want the best care possible for our families and neighbors suffering from serious disease. Next slide. The problem is, according to CDC data here, and here's where you would bring in some of the BRFSS data or some others, that some number of people are living with Alzheimer's and dementia in our state. That number is expected to grow by, again, a certain percentage by 2030. Programs and supports are already inadequate, as caregivers may spend years looking after a spouse, parent, family member, or friend. As Wanda Johnson of Fayetteville said recently, our family would do anything for my mother. That's what we do. But basically, my husband and I have been on our own. Next slide, or next piece. The cause, right, is that quality long-term services and supports exist, but they're underfunded and inaccessible to many people due to location or cost. Families and caregivers, the linchpin of our care system, are often left to fend for themselves. And then ultimately, the solution is, next. Our new state Alzheimer's plan will complement the often heroic efforts of caregivers of people living with dementia, providing better access to programs that deliver support and respite and enable them to continue to work jobs, care for their children, and maintain their health. So again, this gives you just an example of how data is an important part of a message around caregiving. But in fact, it is not the only part of a successful message. And indeed, if you go to the next slide, there are several kind of appeals that need to be made in the course of a successful message. And this comes from no less a source than Aristotle himself back in the Greek days and before the Christian era. But the types of appeals include ethos appeals, which are based on the credibility of the speaker or of the source of the information. There are logos appeals based on logic, inductive or deductive reasoning. There are, and often supported by data. There are pathos appeals based on emotion. And again, those are kind of stories or quotes. And in fact, in the previous message that I just described, there was, again, we added in that quote from a person from Fayetteville who talked about her experience in caregiving. And then the final appeal, or mythos appeals, are based on broadly held cultural values, much like the initial value that we described in the course of the at the beginning of the message example that I just described. And so as you think about your messaging, you want to make sure that, again, that you are demonstrating a sense of credibility, either from the source of the information or from your own personal credibility or the organization's credibility. You want to make sure it's, oh, I just want to go back through there. Sorry. You want to make sure that it includes logos appeals, logical appeals, pathos appeals, and again, that broadly held cultural value as well. Next slide. In order to support those appeals, you'll need different kinds of evidence. And we've been talking today about quantitative evidence, data, if you will, which comes out of the BRFSS, but there also may be qualitative data, statistical data that comes out from research. There's anecdotal evidence that is based on a story and examples that support a general statement. Next. We have testimonials, individuals' stories or expert accounts. Next. We have pictorial schematic evidence. And again, we saw in New Jersey the infographic that was done there, but photos, et cetera. And then analogical evidence, which are sort of the weakest version of evidence, but sort of scenarios, what if, et cetera, or metaphors or similes that help people understand the information that's being presented and support, again, these different types of appeals. So indeed, data can do a lot of work for us in this messaging. And again, the stories in North Dakota and in New Jersey, I think were informative about how data functions. In many ways, data is like, I think, a GPS that helps guide legislators or policymakers or even community members towards what's important. Right, and in North Dakota, you know, the data about the population of people living with dementia and the growth in that population, the growth in caregivers, again, pointed folks to the need for a state Alzheimer's plan. The crosstabs that Janna talked about pointed people to the need for different kinds of chronic disease programs to include people with dementia and their caregivers. So again, the data it was in many ways a guide towards what was important. Similarly, in New Jersey, the data was used again as a way of sort of raising the importance of the issue and supporting the broader legislative agenda, whether that and including the caregiver task force and this sort of piece by piece building of an agenda that, again, I think is starting to make really important progress and impacts for people in New Jersey. And then in California, we didn't hear that story today. The data on caregiving is included in the master plan for aging, and indeed, the data was sufficient to ensure that it was one of the 5 major goals of that master plan. But again, 1.7 million Californians are caregivers of people living with dementia. There's 4 billion hours of unpaid time that are worth $63 billion in care. And they noted a labor shortage of $3.2 million of 3.2 million direct care workers as, again, part of their case for building the direct care workforce and addressing the needs of caregivers with people living with dementia. So again, a lot of ways that the data is a critical piece of the kinds of conversations that we're all trying to have. Next slide. And finally, I just want to talk about a little bit of some cultural considerations, around these communications and around the use of data in our messaging. First of all, that we should realize that, again, who is delivering the message really matters. As I mentioned, ethos in terms of the credibility of the speaker is really important. It's not just the credibility based on a degree or a particular position of authority, but the credibility in a particular community, and indeed, engaging community partners to carry your public health messages can be critical, not only around caregiving and people living with dementia, but also for all issues related to public health, and finding those community collaborators and partners can be critical to successful communications. Indeed, in terms of the language that folks are using, again, we want to make sure, particularly as we're reaching out and communicating into various communities, we want to make sure that the reading level is appropriate. I think all of us as public health communicators know that, we need to be communicating at an 8th grade level, or in some, limited English proficiency communities, even at a 4th or 5th grade level as well. And again, this is not about dumbing things down in any way, shape, or form, but really finding language that is accessible and meaningful to people. Similarly, translation and translators are critical to ensuring that that your messages are understood and can be made sense of, and understanding sort of some of the implications of that translation, particularly around some of the words that we use around Alzheimer's and dementia, is really important. And then again, there is in a lot of public communications some inadvertent aspects of the way we describe different groups, et cetera, in ways that are not particularly helpful. And I would turn people's attention to the Health Equity Style Guide for COVID-19 response, to ensure that that has really good examples of how to and preferred terms that enable us to avoid blaming the victims or folks struggling with a particular disease or a particular community, and that point to the structural barriers, structural racism, structural inequities that are indeed the cause of many of the health disparities that people in communities may be suffering. So I wanted to point to that. Again, you can see at the bottom there that resource from the CDC Style Guide to Health Equity. Also would point people to the very helpful Phrases website funded by the DeBoma Foundation, which includes public health collaboration and storytelling toolkits, which I think are very helpful in terms of building one's message. The Frameworks Institute in Washington, D.C., which is a MacArthur Award-winning institution that focuses on various social issues and communications around social issues, has a whole series of information on public health. And the Diverse Elders Coalition has a very helpful toolkit, Caring for Those Who Care, Meeting the Needs of Diverse Caregivers, which has very helpful national level data on various communities of color throughout in the United States, and how they view dementia and dementia caregiving, which I think can be, which also is I think a very helpful resource as well. So thank you, and I guess that I'll turn it back to Joe and to the questions for me and perhaps for the rest of the group.
Great, thanks, John. Just a wonderful way to wrap up this tremendous webinar today. We have some questions that I'd like to share with you, John, see if we can address.
Yeah.
The first is, and I'm not sure if we'll have these handy, but it's a good question. Are there any examples that can be shared of successful messages that have been implemented?
Successful examples. So I don't have them handy, but I think there's a couple of examples that we heard today on the phone, or particularly around dementia caregiving, and in North Dakota and in New Jersey, where it's pretty clear that the use of the data and the communications were effective in building a larger broader support. So I'm not sure successful. I'm not exactly sure how to kind of gauge that in terms of strong communications around caregiving. I think there are a variety of folks who are working in this area that do a good job. The Family Caregiving Alliance, for example, Alzheimer Association has in general not only in New Jersey but nationally and in other places has a very strong record in bringing attention to these issues. And again, some of the phrases and the frameworks tools actually have some very, very strong examples of public health communications that are successful and effective as well.
Yeah, I mean, I think one point you made very clearly and compellingly, John, was the incorporation and integration of data with story.
Yes.
And, you might want to call it anecdote, qualitative, et cetera. And, I can share a story with regards to that. Is a few years ago, I was asked to testify by the Alzheimer's Association here in Minnesota for what's called the CARE Act on the part of AARP was promoting this new act to basically mandate that hospitals provide information and some degree of training to caregivers to help facilitate hospital discharge. So there were 3 of us that were asked to testify. It was myself. I was kind of the quote unquote caregiving guy, caregiving expert, or whatever you want to say. Then we had a neurologist, a world-renowned neurologist from Mayo Clinic. That was kind of the MD dementia person. Then we had a person with early stage memory loss there to share their story. And I think all of you can see where this is going. You can imagine which of the 3 of us most resonated with that Senate committee. It was the person telling their story, the personal story. But presenting that alongside this data and information, I think was a compelling way to message that actually led to policy change. And so, hearing how John structured all that, I think these are very important lessons for all of us to learn and really adopt in our own work.
Yeah.
So, go ahead, John.
I just might want to say one thing, which is that, again, even though I think there are 2 things, data is a critical part of public health's value particularly in its kind of communication with the legislature and the governor, the governors of the various states, that it is the place where, it can be and should be the place where data drives, it's a source of data, a source of credible data, et cetera. At the same time, the data is generally not the star of the story, right? And so the values and those actual stories that, like you were just describing, of people's struggling with these issues, and particularly people whose stories reflect the benefits of programs and not sort of their own personal heroic stories, almost as much as the programs, for example, the ones in North Dakota that are helping lots of people, and sort of to connect their individual stories to policies and or programs that are helping them is really critical.
Great. Thanks, John, so much. We have some other questions here too. So, John, can you speak to the broader issue of caregiver identification and public health messaging? Some implications for effective public health communication strategies.
Yeah, I saw that, and again, that is an age-old and very challenging question, because, as I think everybody on the phone probably knows, is that, and again, as the CARE Act was designed, most caregivers don't identify themselves as caregivers, right? They are simply sons, daughters, friends who are caring for loved ones, just doing what it is they do, and that interferes with our ability to find them and to get them to think about what they need to take care of themselves and to take care of their loved ones and friends in more effective ways. My sense is that I try to use use a brief descriptive phrase to say caregivers, that is, or caregivers hyphen, family, friends, and others who are who are providing daily care and support to people living with dementia. And that, I think, again, caregiver, I think we want to use the word caregiver, and informal caregiver is another term that people have used. But again, for the most part, I've found that folks don't like that because it's sort of negative and suggests somehow that the formal caregivers, the clinicians, et cetera, are more critical or more important. And then family caregiver is also problematic in part because it's not just family members, and some folks don't have families, and some folks don't have families that are going to support them. So I just do caregivers and then do that brief descriptive phrase. You're muted, I think.
Sorry, John. Thank you so much. That's wonderful. We had one last question here. I don't know, this wasn't for you, John, specifically. I don't know if it was directed to me or maybe some of the other panel members. I'm going to pose it. This may very well be a question that we might have to take back to our center to see if others can answer it, either at CDC or beyond. So who monitors IHSS or in-home support service or caregivers to ensure orphan elders with dementia cognitive decline, so I believe that refers to individuals who do not have caregivers, to ensure orphan elders with dementia or cognitive decline are receiving and signing for service hours allocated billed for. Normally, IHSS states an individual is an employer regardless of mental capacity, ability to monitor services. What spot checking programs are provided or available? I, off the top of my head, can't answer this question. I would need to find the answer. Janna, Phil, I don't know if you have the answer. If not, I'm more than happy to the person who posed this question. I could take this back to our center group and pose it to them and get the answer for you. Janna, Phil, I don't know if you had this answer handy.
I don't, I'm sorry, but I would be interested in the answer too.
Yeah, so what we'll do is we will take this back to our center and try to address. And we have another question coming through here for Phil. Phil, in the context of using stories and lived experience to paint the full picture, do you have any examples of how you use the qualitative data along with BRFSS data for bigger impact through the legislative process in New Jersey?
Yeah, so anytime that I go testify, I always bring a volunteer with us who can not only speak to the qualitative side of things, but just really tie that personal element to these issues. And, I have to say, when legislators are on the floor voting for policies that can impact Alzheimer's and caregivers, I can assure you they're not thinking of the lobbyists and the data that I present them. They're really carrying the stories of their constituents that really impact them, that really move them to make these progressive changes. And it's really those stories that help the change. I mean, quantitative data really just adds the element behind of what qualitative data can really present. And I truly believe that having both really make policy changes occur. Policy doesn't happen in a vacuum, and emotional charge can really make that difference and really can cause a change in the policymaking process.
Thank you, Phil, so very much. John, were you going to add something?
Yeah. I mean, I think again, it goes back to that sort of Aristotelian sort of sense of communication. It's not just one type of communication that is effective. It's a multifaceted communication. It is it's also communication that occurs consistently and that continues over time. That's the other thing that people kind of, I think, in our world are oftentimes, they think, oh well, we're gonna have one testimony or one day on the Hill, and that's going to change everybody's minds, and then all will be well. But in fact, what is at least as important in terms of the delivery of the message is that there are resources and the ability, I think, as Phil's story suggests, and Janna's as well, to continue to build these efforts over time, and that nobody is convinced or moved, or hardly anybody is convinced or moved on day one. And in order to build the coalition and the partnership and the collaborations that are necessary to make real change, that takes multiple communications over a extended period of time to create the impact that that we're all looking for.
Great, thank you, John. All right. Again, the Q&A box is open if you have any additional questions. We are running fairly ahead of time, which is wonderful. This often doesn't happen for me, and I appreciate it. I appreciate the wonderful, concise, but very information-packed presentations of everyone today. And I've learned a lot, certainly, and I hope you have too. I wanted to wrap up with just some reminders for all of you who have attended. I put in the chat, for those of you who use Twitter, or organizations use Twitter, feel free to tweet us. We do have a Twitter account at PHCOE _DC. I put it in the chat. Love to hear your thoughts, etc. Can you please go to the previous slide? Thanks, Kate. Also, too, again, as Elma had mentioned, our website is still under development. The address will be bolddementiacaregiving.org. That should be pretty easy to remember. We hope to have this site fully up and operational in, I think, roughly 2 weeks or so. And on that site, we're going to post today's slides and recording. We may very well develop a toolkit as well out of this conversation in terms of best practice, et cetera, that hopefully you and your organizations can find helpful. Also on this website, you can request technical assistance to support your public health work in dementia caregiving. Again, our center is designed to serve as a resource to public health agencies of all kinds, and we are happy to help. We also are happy to help and engage with you if you're a service provider or provider organization. And we've already fielded several inquiries from those types of organizations because we see all of this linked. We see service provision and public health as inseparable and needing to come together in order to address the public health issue of dementia and as well as dementia caregiving. And then as well, we will have updated calendar of events because our center is getting ramped up. And as you'll see in the next slide, we have a lot of things on tap here for you. So next slide, please, Kate. And in fact, we will have our next webinar coming up on June 30th. And it ties directly to some of the material John was talking about, which is really cultural adaptation. What do we need to know? How do we need to tailor our messaging, our services, our programs, our communication to be culturally appropriate? And within our Public Health Center of Excellence on Dementia Caregiving, we have a superb, what we call Health Equity Task Force that is taking the lead and will be delivering the first of what's going to be a 3-part webinar series on cultural adaptation. So again, really thrilled to hopefully have you attend that event as well. So in terms of follow-up and final comments here, we will be emailing you, again, the slides, as well as a link to the recording of today's presentation, as well as an evaluation form. So on that form, again, we would ask you if you have additional ideas, thoughts, topics that you think our center should be presenting and covering that would be most helpful to you, we are always welcome to that. So I think with that, we are going to conclude. Again, tweet us, email us. Again, if you want to learn more about BRFSS, we've put together a number of resources for you that we will email out. Again, CDC and the Alzheimer's Association, as well as others, have put together a fabulous series on BRFSS basics. Introduction to the survey in general, the different modules, and again, really, really great material. And we really encourage you and your organization to check that out as well. And then finally, some additional resources for you here too that will be shared with you when we email out all of the information from today's webinar. Any final thoughts or comments, Alma?
No, thank you very much for attending today, to our speakers for sharing their stories. I hope you all leave here with something actionable, something valuable for your work every day. And feel free to reach back out to us with any questions, any ideas, anything else you would like to share and learn more about.
Yeah, that's something we very much would like to hear from you about. So wonderful. Preeti, for some reason it says we cannot see the last slide, but again, all it says, Preeti, is thank you for joining us. So you don't have to worry about that too much. We were going to send out a poll. Were we, Kate, now? I think we should send out an email evaluation link because people are leaving already. So, I mean, we had over 100 attendees. There's 60 left. We shouldn't be putting out a poll.
I believe when people close the Zoom, the poll will show up automatically. Okay. And it will also be emailed.
Good. So hopefully they're completing it that way. But again, yeah, we should send it via email as well. But thank you, everyone. Again, wonderful presentations. Great way to kick off our formal educational programming of our center. And again, we encourage you to reach out to us. We can't wait to hear from you and to see you again. Thanks, everyone. Have a great rest of your afternoon.